had pneumonia, and the patient was doing well. We switched from nasal cannula to simple O2 mask, and now we've gone all the way up to a non-rebreathing mask. This patient is now lethargic. We've done a blood gas, and the blood gas states that this patient is impending failure, meaning the pH is anywhere from 720 to 730, right? And when they're impending failure, CO2 is high, O2 is low, right? We have to make a decision of whether we can put this patient on non-invasive mechanical ventilation such as a BiPAP, or place the patient on a conventional continuous mechanical ventilator, right? So what we have to look at is this patient's ability to be able to follow simple commands and or to protect this patient's airway. Now this patient is now lethargic, so obviously their ability to follow simple commands is going to be very decreased, and at the same time their ability to be able to protect their airway is also decreased. So instead of a BiPAP, we're going to want to intubate and place this patient on mechanical ventilation. Okay? After the blood gas is being given to the physician is probably going to want to give an order to intubate this patient. Again, this patient is impending failure, they're lethargic, they're not going to be able to follow simple commands and or protect their airway. Now, this is going to be a controlled intubation. This patient is currently on, I won't turn it on so you guys can hear me. This patient is going to be on a non-rebreathing mask, right? And we want to make sure that we have enough flow, and we have enough flow as long as the bag only deflates by how much? 1/3 on. Inspiration, expiration. Inspiration, good. So the only 1/3 on inspiration, right? All right, so the patient's getting 100% O2. Now, obviously, there's an order for intubation. Doctor wants to intubate this patient and place him on mechanical ventilation. All right, so the nurse is probably also going to get orders, right, to sedate the patient or give the patient a paralytic just for intubation. So what paralytic are we going to use for intubation? What paralytic are we going to use just for intubation? Oh yeah, didn't we?
The white one.
No? What?
Wait, to sedate or to?
Paralyzed.
Okay.
I said
Oh.
which, right? The doctors kind of want to give a paralytic, right? So he or she can intubate this patient. Remember I said, to be you.
Oh, yeah. Because you're intubating, it's like
Succinate choline.
Yes.
Now we can give fentanyl, we can give a sedative for intubation, but in this case we're going to give a paralytic, right? Succinate choline. And so you, as a therapist, you need to find out exactly when this nurse is going to give the succinate choline, because once they give it, you're going to have to start what for the patient? You're going to have to start what? Bagging and breathing for the patient. You can't intubate. You're here to what? Assist in intubation, which is way more important than intubating, because the likelihood of you guys intubating even during rotation is going to be very highly unlikely. And even as a therapist, when you graduate, highly unlikely you guys will be intubating, but you will be, right, asked and probably need to assist in intubation almost right away. Okay? All right, so if I know that this patient is going to be intubated, or like I said, we are already in pending failure, the patient's lethargic, the patient needs to be on continuous mechanical ventilation, right? So obviously I know all that's going to happen, so therefore I already brought a ventilator. I set up the ventilator, which you guys will learn, right, in your critical care rotation, or before that when you guys are in that lecture, right? And I'm going to set up the ventilator with the vent settings I think are appropriate for this individual. So that's already there, ready to go, right? And before I even do anything else with this patient, I'm going to want to wash my hands, right? Wash my hands. Right, and how long do I wash my hands for?
20 seconds.
How many seconds? 15 seconds, right? 15 to 20 seconds, totally fine, right? Now you can wash your hands, or you can wash your hands or use an antiseptic gel, right? Or antiseptic gel. You always wash your hands if you're dealing with what kind of patients?
Contact.
Use antiseptic gel if they have infection with what?
Contact.
C. Thank you. They'll get there, Mr.
I just feel like I'm in pain every time they answer right now. Like a
They'll get
torture.
there. All right. Well, anyways, Dr. Inami will be on his way to intubate this patient. So, before the nurse will give the succinate choline, I'm gonna tell her, hey, let me set up first, okay? So I'm gonna get my intubation tray, okay? Excuse me, right? Sorry. Bring this with me. Excuse me. We get a side table. A lot of hospital rooms may have a side table. If not, you're just gonna put it on the tray. Sometimes we'll put it on the patient's bed. I have a side table, so this is what I'm gonna do. All right. So a couple things I need to check, right? Or I must have for this intubation assistant. The patient is still breathing, obviously 100%, and they're not doing well. The CO2 is high, the pH is acidic, right? Oxygenation is probably low, but we need to set up this intubation. So, a couple things I need, I'm gonna first of all, we're gonna intubate, so I'm gonna look for a laryngoscope blade. Now, the laryngoscope blade that we're gonna be focusing on for adult is what? Curved or straight? Curved blade usually for adult. No, not curved. Is it curved? Curved for adults, I'm sorry. Yes. Right, so I'm gonna look for a curved blade. Most doctors like to use curved blade for adults, so I have a curved blade here. And then I'm gonna take the laryngoscope blade. So let me open this on a brand new one. And then I'm gonna wanna connect this laryngoscope handle with this blade. It's made out of metal. This is all disposable. Connect it. Is this the right one? Okay, there you go. Alright, so it's connected. I'm gonna open it. It's not in all the way. Oh, no wonder. Something's already stuck in there. It got stuck. Alright, I'm gonna open a new blade. Okay. Got a new blade. Alright, so you put the blade onto the handle this way, and you open it. Alright? And Mr. Nagi.
And you'll be still while doing this?
Huh? No, you don't need
You
this.
don't have to do this,
Hey, look, brand new handle, brand new blade.
Do you want me to get, we have one that's nice. Let me go get. let
You
me
know,
go
there's,
get it.
can you just get that box? The box is still right there. Maybe find it and get another handle. It doesn't feel like there's a battery in here. It could be old, the battery could be dead. Alright, so that's one of the things that we do. No, the box is right there to your right. All the way to your right. All the way, the brown box, yeah. See if you can find another handle. So usually it comes like this, right, by itself and a blade, and you take it. Then that's why you want to check these things, right? Because when you snap it together, what you're supposed to see here at the end is going to be a bright light. Because I mean, when you're looking at the glottic opening, it's going to be dark there, right? And the light's going to help you see the glottic opening in the vocal cord. Any more handles there?
No handles.
Okay, can you use a straight blade? Dr. Nami, can you use a straight blade instead of a curved blade?
I don't like straight blade.
These picky doctors, seriously.
Let me go get you.
This one is dim. No, it's the handle.
Yeah, let me go get you one.
Yeah.
Swords.
That's straight.
No, I
Is
don't
that,
like straight.
what is that?
It is an X-ray blade.
Yeah, it's a straight blade.
And what about the handle? Oh, here you go.
It's an old one.
It work? Okay. Alright, so here I have this old one, this non-disposable one. So for these to be clean, these blades to be clean, they have to go through where? How's this
Autoclave.
going to be clean? Autoclave, right? So this is gonna be autoclave, right? And then I open it, and it's an older, right, laryngoscope blade, so it has a yellow lens there, but it should be bright enough. So how you check to make sure it's bright enough, I usually will shine it on my eye. If I squint a little bit, that's good enough. Right now, this is an old halogen light bulb, so this will heat up. It's not LED, so I will close this one, because otherwise, if I keep it open, it'll heat up the whole blade, and then when you put it in the mouth, it can burn the tongue. Right, so this one I'll close, and I'll put it to the side. Okay? Alright, next thing I'm gonna get is the ET tube itself. Now, the ET tube, right, you gotta use the appropriate size for right now, for inside the classroom. Again, male, what size ET tube?
8.5.
And female?
7.5.
In the real world, it's gonna be all about height and weight, right? So female can have a bigger one, or male can have even a smaller one, but for board exam, those are the things we're gonna use. Alright, so I'm gonna take the stylet, right? Now remember, this allows the ET tube to be more rigid, so it doesn't bend while I'm inserting it, right? As I insert it, I'm gonna look inside. As you can see, I'm not taking the tube out of the plastic because this has to stay pretty sterile still, right? So I'm gonna put it in here, and then I'm gonna make sure it goes all the way to near the tip of the ET tube, but not past the Murphy's eye. The Murphy's eye is a little hole on the side of the tube. And I don't want the stylet to go past the Murphy's eye or the tip, because if that stylet goes through it, it can potentially stick out and traumatize the airway, right? But I just need it to be mostly in there so I can make the ET tube malleable. See that? I can bend it to whatever I want. So in this case, I like the airway that's kind of bent like this, so I'll leave it like this. The next thing I want to do is I want to take the syringe. I have a syringe in here somewhere. Where's my syringe? Do you see it? Here's my syringe, and again, without taking the tube out of the bag, I'm gonna take it and pull it all the way back, and I'm going to inflate, right, the cuff as much as I can until it feels fully full, and I'm gonna feel for it. As I squeeze the cuff, I wanna make sure it does not deflate. If it's hold pressure, then it's good. So it's holding pressure, so I know that the cuff is intact, we're good to go. So I'm going to deflate it. Remember, you cannot insert this ET tube while it is inflated. You're gonna cause a lot of trauma. Okay, so you have to be the one, well, it won't be inserted inflated anyways, because if you give it to your doctor inflated, he's gonna look at you like, what the hell's wrong with you, right? Okay, he's gonna be like, get out of my patient's room. Okay? Can we see that look? If you see this thing inflated, give us that look. I wanna
I'm
see
just
that
gonna
look.
have that. I'm just gonna throw it.
Okay, so I usually, once I check this, I wanna keep it right at the patient. Okay, next thing I wanna look for is this. This is the end side of, right? Colorimetric capnometer. What is it supposed to detect? CO2. What color do I need it to be?
Yellow.
Gold or yellow. From?
3 to 5.
No, from purple to, from purple or blue to gold or yellow. And if it turns purple, how many percent CO2 is that? 3 to 5 what? Percent, 3 to 5%. Okay, so here it is. There is purple, and it should turn to yellow, and it says here 5, right? Okay, 5% is optimal, of course. Okay, so that's what I want. So I'm gonna put this at bedside. Okay, next thing I need is going to be the laryngoscope blade. Which one do we get? Oh yeah, it's already there. Sorry, and then let's see. So I have the syringe. I'll keep the syringe here also. Make sure I don't lose it. Then I will use this right here. This is my ET tube holder. Mr. Nami wants me to show you guys how to do it with a tape. If you don't have something like this, we'll do that one next time. But for today, just this, right? So this is the ET tube holder. What is the specific name of this one?
Anchor fast.
This is the anchor fast? Okay. And there's a Hollister also.
Hollister, yeah.
Okay, so this is the anchor fast. This one does not have a bite block, right? There are some that has a bite block included. This one does not. Okay. Do we have a bunch of these somewhere? A bunch of these brand new ones?
Couple more, yeah, I think so.
Alright, so I'll leave this one for now, but I know that this is here. And lastly, what I didn't do, this is lube, right? So what I'm gonna do is, I'm going to lube the tip of this tube. So when I take it out, I'll make sure it doesn't touch anything. So I put up in the air, I'll rip this open, and then I will drizzle some lube at the tip without touching it at all, because this is contaminated, right? I touched it. So if I touch it like this, right, then obviously that tip is contaminated. I'm putting that right into the lungs, and I may cause what? Pneumonia. That can lead to yes, right? So you're gonna be the one to cause that if you did that. So you would just what? Squeeze it and drizzle it on here, and then put it back in. As you put it back in, it's still sterile inside if you just open this. And when you put it inside, it should kind of like, you know, smear it onto the rest of the tube, and it should be okay. Right? So that's it. All right, so the next thing I want to do now the nurse can probably start giving the medication, because I'm going to start breathing for this patient, okay? So I'm going to look for our manual resuscitator. Plug this thing in. Okay. So I want to make sure my suction works, right? Here's my suction. Now again, Most doctors want to suction the upper airways prior to intubating, right? So I want to check my suction. Now, obviously, I want to be between 120 and 150, correct? Now, if we're just orally intubating, because I know that's what the doctor's going to initially do, I'm probably going to put up even more, right? I can go to 200 because I want him to be able to suction a lot. It's just orally, we're not going to suck out this patient's air, we're not going to cause atelectasis, so that's okay. But it's your job, once he's done sucking out the mouth, it's your job to bring the suction pressure back down when you connect this patient back on the ventilator, right? Anything higher than negative 150, right? You're gonna cause a lot more problems with hypoxemia, vasovagal effects, and or trauma, correct? Okay, so I'm gonna put it up really high for right now, just for oral suction. Okay, so that's the first section we're gonna do, so I'm gonna leave this connected. Back here. Now usually we're gonna have a thing here to keep it clean, but this is where I have it right now. Okay, so next thing I wanna do is, I know this patient is going to be, right, it's gonna be intubated, so what I wanna do is, so that we can put this patient's head in a good, nice nipping position when we're manually ventilating, right? I'm gonna lay down this patient's bed. Now, the problem with laying down this patient's bed is I'm not gonna leave this patient in this position for a long time. Why do I wanna lift this patient's bed to what degree? 30 degrees, why? To prevent aspiration, good. All right, so I wanna make sure this patient is flat. I'm gonna take the pillow out, because with the pillow, it's gonna be hard to get into that nice nipping position, right? Now, intubation is gonna be really tough. Intubation is gonna be really tough with the head this, and the bed this low. So if I'm able to, and this bed's already as high as we can, I think, for this, for this bed, I'd like, and the beds in the hospital will go a little higher, because the eye has to be able to look directly into the airway. If it's this low, it's gonna be hard to be able to see this airway, and if they can't see the airway, your doctor may ask for you to do what on the neck? Cricoid pressure. Did you guys hear that? Right, that's gonna push the airway lower, so from a higher angle, they'll be able to see it. Okay? So that's called what? Cricoid pressure. Very good. Okay. All right, so what I'm doing right now is I'm pulling the bed out a little bit, because I need to get at the back of this patient. All right, so now this patient, right, let me increase, the patient's getting a lot of oxygen. Right, so now this patient is gonna get the medication and they're going to be paralyzed. Can you bring that? Now, what is the number one cause of upper airway obstruction for an adult patient when they become unconscious? Their tongue. So what do I need? A what? An OPA. So that's what I forgot to look for, and here's the OPA, right? So this is part of lab, right? How are we gonna put this in? Upside down first, right? So the airway is going this way, it's gonna be this way, but you put it in upside down, and we'll be checking for that when we come back from break. So I'm going to take this out, right? I'm going to disconnect this and connect the bag. Now it's okay, I'm not giving any breaths right now, the patient's not getting O2, but that's only a couple seconds, right? And I'm gonna put this upside down like this, right? Now remember, how do we check this again? To make sure this is adequate size? From the mouth to the jaw, right? So on this side, it would be like this, right? So we've got a little bit lower than the jawline, but it's gonna be right at the jawline, right? Or this way as well, okay? So I'm gonna insert this upside down, and as I insert it, I'm going to twist it like this. Got it? So now this is gonna hold the tongue down and prevent it from falling back. Okay. Now, you guys have learned how to do manual ventilating with positive pressure back, correct? You guys didn't do CPR? So look at the contour and the shape of the mask. Remember, this always goes right here at the bridge of the nose, and the bottom piece will go where? Below the lips, but not below the chin. It's gotta be below the lips. Then you use your EC clamp, right? So C right here, E down here, the E holds onto the jaw, and then your C, your thumb and index fingers, goes right on top of the mask, and you are going to use your E to pull the patient in sniffing position, right? And then the C to push down on the face to make a good seal. right? And then you wanna give breaths, okay? So I don't have a good seal. It's hard to get a
I
good
don't
seal.
think it's gonna.
So
I
I'm gonna
don't
give a
think it's
breath.
gonna
Now
expand.
remember, you're giving a big breath here, right? Okay, this is a 1.5 liter, maybe 2 liter bag, right? And you don't need to be giving that big of a breath, okay? So, but you're not gonna squeeze everything in. You might give like 800, 700 or so. So just squeeze and feel for the resistance of the bag. And you wanna look for chest rise. And remember, when you give breath, you wanna give breath like this. Breathe. 2, 3, 4, 5. Breathe. Don't be breathing like this. Right? What am I doing if I breathe like this? I'm hyperventilating and I'm blowing off what? CO2. Now this patient's CO2 may be very little high, but your big tidal bond itself should be able to ventilate this patient, right, before the intubation. So just calm down, don't get excited. Breathe. 2, 3, 4, 5. Breathe. 2, 3, 4, 5. That's every 5 seconds. How many breaths am I giving in a minute? What? 12 breaths per minute, right? The normal breath rate is 12 to 20, okay? All right, so I'm gonna give breaths, and I'm gonna look at the monitor, and look at the saturation, look at the heart rate, look at the blood pressure, and I'm gonna do this until my doctor walks in, okay? So, Dr. Anani
Ready?
is gonna walk in, we're ready to intubate. So I'm gonna move this way, and I'm gonna show you how it can really be. He's coming in this way, right? But I need to move this way, because I need to be on the right side. And I'll show you in a little bit why I need to be in the right side. So sometimes this is what you just gotta do, right? I'm gonna give a good couple breaths, because I'm not gonna breathe for a little bit unless the doctor wants to breathe for the patient. And I'm gonna find a way to get under here and get out of this crazy situation, right? Alright, so here I am. I'm gonna take this and, okay, so we're about ready to intubate here. So the doctor's gonna drop this bag.
Sedate and
Right.
paralyzed.
The
Sedate and
patient-
paralyzed.
Yes, the patient is sedated and paralyzed, the nurse already gave it. I'm gonna pull this out, and I'm gonna give the laryngoscope blade and handle to the doctor, and the doctor will look. Now, as the doctor starts looking, I'm gonna hand this to the doctor, because he's gonna wanna look to see and look for the airway. Okay, so I'm just gonna give it right there. He already knows what he's gonna get, right? And he suction, and now I'm gonna hand him the ET tube this way, not this way. He's not gonna enter it this way, so you have to give it, he's not gonna look away anymore. So he's waiting for the tube, he's gonna intubate that way, right?
Right, please.
Okay, so tricoid pressure. Okay, good. I'm gonna pull this out. I'm going to inflate the cuff, right? The cuff is inflated. I'm gonna take this out, right? And I'm going to take the CO2 detector, put it on the tube here, and I'm gonna connect it here. Right, so the doctor, if he can, will start to manually ventilate the patient, and then I'm gonna take my stethoscope, and I'm gonna listen for bilateral breath sounds. If I only hear breath sounds on the right, what probably happens? Good, intubation of the right main stem. So I'm looking for, right, bilateral breath sounds. And then since I'm already listening and I have my stethoscope in my ear, I'm gonna check the stomach. Where? Right or left side?
Left.
Left side, that's where the stomach is, right? So I'm listening for positive pressure in the stomach. And then, since I'm already here, right, I'm gonna look for chest rise, bilateral chest rise, then I'm gonna move my way up, and I'm gonna look for entitled CO2 capnometer, look for the gold or yellow color, and then I'm gonna look for condensation. So what I do is I will listen, look, look. Right? Listen, then look. Right? 5 L's. Okay? Now under MBRC, what's the most important? Bilateral breath sounds, and number 2 is entitled CO2. But you're wasting time because you're going back and forth. So I go here, and then I move up. Okay, but test questions, breath sounds first, entitled CO2 next, the rest, no order. Any questions? All right, so if all my 5 things are good, I have bilateral breath sounds, bilateral chest rise, no positive pressure in the stomach during ventilation, I have condensation tubing and a positive color change, then what I will do is take my ET tube holder, and then I'm gonna try to find my way back in here. And the doctor's probably like, hurry up, I need to go write orders, right? And then, since everything was good, right, I'm gonna look at the ET tube to find out where it is, right? I can't see with my glasses, sorry. I'm at 24. Where should it be at? 19 to 24 for adults. Anything greater than 24, like 25, 27, 26, could be where? Past the carina, either in the right or left main stem. It depends on the chest rise, correct? Okay, so while that's happening, while the doctor's still, right, giving breaths for me, I can secure this ET tube. Okay, I'm gonna show you guys how to use this and work this. And I try not to let go of the ET tube at all. Okay, thank you. And then I will, now that I saw it turn color, I will do this.
You're the one touching.
And then I'm gonna breathe for this patient, right? And then he's probably gonna leave and start writing orders. I may ask the nurse to breathe, right, for my patient, or may ask another RT. Usually I won't bother another RT because they have their own workload. I'll probably ask the nurse to bag for like a couple of minutes, because this is her or his patient also. Does that make sense? So I'll probably ask them to bag. So, Gia, can you bag the patient? In your head, you're gonna count 3, 2, 3, 4, 5, and then I will turn on the ventilator. So let's say I turn on the ventilator. Turn on the ventilator. Now, as you can see, it gets really messy around here, right, with all the equipment. But that's something that you will have to clean then once everything is kind of settled. Okay, so here's my ventilator. This thing's all. Okay, remember this is a, what is this called?
Closed suction catheter.
Good, closed suction catheter, right? And we use a closed suction one as opposed to open one to decrease what?
Valves.
Valves, very good. Alright, so take out this elbow, right here, turn on the ventilator. If it's awaiting and turning, it's ready to go. What I'll do is just, patient, thank you for reading for my patient, connect it here. And then, there you have it. Then the ventilator will start. We start giving breath to the patient, right? And then I'll assess the patient's vitals. I'll assess the patient's ventilator parameters. As long as everything's okay, I'll set up the alarms. And then 30 minutes later, 20 minutes later, someone will come in and do a chest x-ray to see exactly where that ET tube is in the lungs, right? And then I'm gonna go get my blood gasket. I'm gonna do an ABG. And the ABG will tell me if I'm ventilating the patient correctly, too much or not enough, or if we're oxygenating the patient too much, correctly, or under, right? And that's what we'll do. We'll get blood gas, and then we may have to change the ventilator settings based on the blood gas. But as you can see, right, who did a lot of work here? The person intubating or the one assisting?
Assisting.
There you are. That's why it's really important for you to understand and know all of this process, okay? And that's assisting in intubation. Any question? All right, yes.
For the ABG, you said you did it after the X-ray, or?
You can do it before or after the X-ray, but it's gotta be at least 20 minutes or later, because you've gotta wait for the ventilator settings, like the rate and tidal bomb that creates a minute volume for the CO2, or the oxygen with a PEEP that oxygenates the patient. You need those to really take in full effect, right, for you to be able to blood gas. And then, so you know that those settings are causing the blood gas to look as such. Okay, and after that, if the blood gas looks good, then what are we gonna do? Leave it alone, we're good. If the blood gas looks like we're overventilating, then we can lower our rate or lower our tidal volume if it's too much. Or if the patient oxygenation is way too high, then we'll drop our FiO2 down. If they're still not oxygenating enough and we're already 100% O2, then we might increase our PEEP. Because PEEP is a pressure, right, that does what to the alveoli? Well, if it's not open, it's gonna what? Recruit, right? It recruits allostatic alveoli by increasing what? That's with an F. FRC, right? Because when there is a lot of atelectasis, FRC is low, so we have to bring FRC back to normal, and when we bring it back to normal, that means we're recruiting allostatic alveolus. Okay? So remember, everything I've said has come back where? Around, and everything is connecting, right? Okay? Any more questions?
Is it normal for it to stick out like that?
What was that?
The
The tube? Yeah.
tube, yeah.
That's how it is, just sticks out like that, and we have an arm, right, so usually I'll set up this arm, and I wanna make sure that this, ventilator is stable, it doesn't move, because if it moves, it may pull the tube out, right? So usually we have this, arm. Now, here's the thing, since this is on this side and my patient's on that side, so I normally will move this, right, to the other side. So there is one here at the other side. I'll move this. As such. And then they'll hold it up. And then I just clean up my mess.
When do you put that pillow on